Okay, thank you all for joining the continuing presentation for Dr. Meyer. She is going to be able to provide us with some additional information related to resources and an approach to begin to look at the fourth trimester and beyond, and really specifically discussing supporting recovery while parenting. One of the things that I just would like to recommend that everyone please put their questions in the chat box. Just because we have a high number of participants in this group, you can put the questions in either the Zoom chat or in the Whova chat box, whichever works easiest. But I really would like to open this up and have more of a dialogue as we continue to listen to the valuable information and expertise that Dr. Meyer has started us off with and will continue. So with that, I would like to turn it back over to Dr. Meyer. Thank you so much.
There, I moved all my mute stuff. Thank you so much. And again, I can't emphasize how much I want to hear from you guys. I really, I only put a couple of slides in here, and I realized I probably could have put some of the resources in here. I'll tell you what they are. I can tell you what they are later, but they're easy to find. But, you know, we don't know a tremendous amount about outcomes after women deliver. And there are a lot of reasons for that. I have tried to get at this data myself. I've been particularly interested in it, especially since we moved people from being in our tertiary care center out to the state. I was like, I want to know, are they still doing okay? But I didn't have a good, easy data collection tool. We're a small state, so I could call up people and kind of get an idea of what was going on. But, you know, but it remains a challenge because patients move from one provider to another. So nobody really knows exactly how they're doing or what's faring. And so I actually posed this question to a really smart epidemiologist. And there we go. And worked with who's in Maine. And so we pulled both Maine and Vermont data. And we, again, used the claims data approach. And as someone that puts these codes, these diagnostic codes into a chart, I know all too well the limitations of that particular approach. So I'm not pretending that we necessarily know that it's like the best way to do it, but I'm just saying it's the way we got. And so we actually did a study. So this was looking at all women with Medicaid from 2010 to 2018. And I wanted to know specifically, I had been concerned from way back when that women were falling out of treatment at like 3 or 4 months postpartum. And it was too hard. I couldn't figure out a way to measure that because I didn't have access to the records or the data sources of patients to be able to follow them for that long. So we went into the claims data and we looked at 5 months before they delivered to 1 year after they delivered. And we did this in Maine and in Vermont. And I'm just going to focus on the Vermont data. I don't think that the differences in the states matters that much. And we looked at what that trajectory looked like in that postpartum care period in women that were on methadone, which is the top graph here, and women that are on buprenorphine, which is the bottom graph here. And we obviously use more buprenorphine. And actually, this is the dark line is 2010, and the dashed line is 2018. As you can see, there is an uptick, you know, in women that are starting methadone during their pregnancy. This blue line represents when they deliver. And then this part over here is when they're postpartum up to a year. And I will tell you that in Vermont, we have very generous Medicaid, and all these women are covered for a year. And here's where it is in buprenorphine. And first, you can see in 2010, we used a lot more buprenorphine than we did in 2018, which was one of the things I was a little concerned about. But as you can see, and this is what I was observing in the clinic back in 2010, was you can see this is 3 months right here. And look at this fall off, you know, in the postpartum. And this is especially with buprenorphine, but of course it is also more common, you know, the more commonly prescribed medication. In 2010, by 2018, it looked like we maybe had mitigated that somewhat by switching to methadone for some of the highest risk patients. But, you know, you still just see this little diminution down there postpartum. And I will tell you, this is, you know, I was concerned. We just published these data. So I've been a little concerned about that. And I think that it just warrants real care of understanding what's going on in women's lives postpartum, of which we still, I feel like, do not understand enough in terms of the challenges they had. I put this slide in here because I love this construct. This is from Liz Kranz and Marion Jarolinsky, and they're super smart there in Pittsburgh. And I'm not gonna, this was actually a study, but basically what I like this graph because it lets you just think about the construct of how women experience their treatment in pregnancy and then into postpartum. And so they identified people as early initiators. They'd gotten to treatment, stayed in treatment. Then they found people that were early initiators. You know, they still started then, not quite as early as the early ones, but they had okay adherence, but maybe not great. And then there are the people that started early, but then they just could not maintain their adherence. And then there were women that started early and just couldn't get, you know, pretty rapidly fell out of treatment. And there are the people that come very late to treatment, but remain adherent. And then there are the people that come in late to treatment and still struggle with adherence. And this was just kind of describing this population and what their trajectories were. I bring it up here because I like the idea of thinking about it this way and perhaps breaking down to understand how these different trajectories work. There's not a lot about postpartum adherence in the literature. And I try not to put slides out there about that don't have a good evidence base. I know I have a lot of theories, and this is where, again, I really would like the idea of this being a bit more interactive, because I feel like women really want to parent. A key to their parent is going to be retention and recovery. I didn't want to put up, there is some literature on retention postpartum, but I do feel like there are some very structural components that are important. What their experience with DCF is, how stable their housing is, whether they have transportation. But I'll be honest with you, the thing that I am the most concerned about is, especially as we transition to primary, transition women from maybe an OB care provision where they're having lots of visits all the time, everything's all about the baby. We all know, well, many of us know what 3 months postpartum feels like. You get a little tired, the sort of a novelty and the focus of the pregnancy comes off. That's one component. And also think about what we're asking these postpartum women to do. They need to go to counseling. They need to go to their MAT appointments. They oftentimes by that time have to satisfy a lot of their other obligations in terms of work release, trying to go back to work. They're juggling childcare and transportation. And especially in rural areas, what do a lot of rural providers do when people aren't that compliant? Well, the feeling that you needed to prescribe for them anyway because they're pregnant feels like it's kind of waning. They're maybe not that compliant. And so they end up sort of saying, you know what, you're not a good candidate for office-based treatment and perhaps fall out of treatment. So I feel like at least at the provider level, we may be able to control that one tiny piece. But breaking that down and what that means for the state has still been a challenge because these are just population-based data. And especially in rural areas, right? Those are huge swaths of land. It's very difficult to get good data about this. And so I didn't want to give another talk because you're probably tired of listening to me, but I would like to hear from you guys through the messaging or however about what your questions are, what your experiences are about this year postpartum. It's obviously very important in terms of retention and what barriers you have and what tools you think might help you or your community to keep women engaged in treatment during the postpartum period. Mm-hmm. So with that, I kind of want to, I only can see this chat box. I don't know if there's another chat box I can't see. But
there are a couple chat boxes. I think you're looking at Zoom. Dr. Meyer, I can read what I am seeing in Zoom and I'll monitor the other chat box as well. So we do have one question that came in, well, two of them. Any advice on how our clients can better manage hyperemesis while receiving MAT during pregnancy?
Yeah. That is such a hard thing. Generally, what we do is reassure them that really they get pretty much their whole dose. And I know there are MAT providers that are way smarter than me about this, but I believe it's like 5 or 7 minutes is all those pills need to be sublingual to be retained. And remember, because it's sublingual, it doesn't really matter for your GI tract. So to reassure them that if they vomit, almost all of them are going to get enough of a dose. Every so often we'll get a call from the methadone clinic and give somebody an extra half a dose, and that's true for oral methadone as well. It does not need to be retained for a long time. Hyperemesis, right? Sadly, it's a reality in pregnancy. We don't know actually why women vomit so much, but Zofran is effective, Compazine, Phenergan, B6 and Unisom work very well. But to mostly reassure people, those meds don't need to be retained for a long time for you to get the effective dose.
Yeah. It's just a follow-up comment to that question that indicates that she asked the question because she has clients reluctant to continue to take methadone because of this.
Yeah, that's too bad. I would think that their withdrawal would be worse. And I would say absolutely to just work on optimizing their medications, preemptively taking, we use a lot of the fast acting oral dissolvable Dansetron tablets, try that 15 minutes before their dose. But mostly reassurance that first, the good news is your vomiting will get better. It almost always does. Second, that even if you are vomiting, then usually most of your dose is going to be absorbed anyway because it doesn't take very long.
Okay, thank you. Here's another question. I'm curious to hear more about best practices for pain management during the immediate postpartum period.
Oh, that's such a favorite topic of mine. You might know that. That's my new hobby.
There you go.
Yeah, I have like a whole talk on that, but I can give you the 5-minute summation. But if you're wondering, you can always email me, and that's true for anybody. I don't mind if you email me. Here is the bottom line, because I realize we are trying to train all the anesthesiologists in the world out there, but we're still having issues. First, do not change their MAT medication. That is risky for the patient. We all know that. and it will not help their pain management. I know that the anesthesiologists think so, sometimes the OBs think so, but that's not true. It's a long story. We have data. Second, women, remember, all of these women are very opioid tolerant. It is not at all surprising that they need a bit higher doses if, say, they have a C-section. I will tell you, vaginal delivery, same. So they shouldn't need opioids. So we're really just talking about C-sections or maybe some complicated vaginal deliveries. But if they really need opioids, they are going to need about 30 to 50% higher dose. They don't need it for any longer. They'll just need a little higher dose. We keep their MAT exactly the same. Add the short-acting opioids on top of it. We have really pretty good success with that. There's a lot of other ancillary adjunct anesthesia tools that you can use, but they're not available at every small hospital. And these are actually what we use, and they work pretty well. Epidurals are just as effective, basically, in women on MAT as women that are not. They work very well. Same thing, for C-sections, spinals, epidurals, still equally effective. The most important thing is to maintain their MAT, because you can imagine that if you start to wean their MAT or withhold their MAT, they're going to go into withdrawal, and then they're really going to be uncomfortable. So just maintain them and give them a little bit more opioid, but it doesn't need to be any longer. Many of them don't need any more than 3 or 4 days after discharge from a section. But there's a lot more to say about that, and you can put in the chat if you have another more specific question than that, but it can be managed.
Excellent. Okay. We've got a few more questions. One is, we are collecting data on clients about 5 to 7 months after the birth. Do you have any suggestions for important questions to ask our clients at this time?
That is an awesome question. And I have not thought about that a lot. So I'm going to just be kind of making it up right now. But since I have been thinking about this for a while, first, everybody knows the particulars of their community. So first, obviously, kind of go with your gut. You might already have an idea of what's going on. I want to know what their specific barriers are to continuing treatment. Are they in treatment? If they are not in treatment, why is that? Did they decide to come out of treatment? Did treatment become too complicated in their life with their kids? Did family or somebody else ask them not to come out of treatment? I really want to go after, I left this slide up here for a reason. I want to go after, why are you not in treatment? Because we know from non-pregnant studies, their best bet for parenting, their best bet for recovery is going to be retention and treatment. We don't know for how long, but I can assure you, if you have a small child at home, and I tell patients this when they ask, because some of them want to wean immediately postpartum, and I'm like, it's pretty stressful to have a baby. Why don't you just hold that until you feel like your life is sort of coming together, and that you feel like you have a job and stable housing and your life is relatively stable, and think about your recovery and then come off. Because for some people, they'll come into treatment only in pregnancy, and then they'll be like, okay, now I'm not pregnant anymore, I'm done with it. So I would like to know why they're not in treatment. And if they are in treatment, what's working well for them, right? How is it that you're successfully in treatment? And I really want to know, what are the things specifically that patients want us to know about parenting and being in recovery? And I think that you're going to need to have a pretty trusting relationship with them to get that information. But I know that those are the things that I really, really want to know. Why are you not in treatment if you're not? How did you manage to stay in treatment? Was it easy? Was it hard? What kind of supports do you have? And what do you wish people knew about what your life is like? And what do you think could make it easier? I know that for us, the conflicting priorities are a huge issue. They have the judicial system going after them. They feel like they have DCF having demands on them. Their MAT provider has demands on them. And those three groups of people are not talking to each other. And so they have I couldn't manage the schedules that some of my patients will show to me. So I want to know what their lived life looks like a little bit, because I feel like we as a system can probably improve it, which I'll be honest with you is why, when I looked at these data, I was like, we need to do something a little differently in our state. And that was actually an email I sent this morning, because I want to actually get the labor people, I want to get some employment and job training stuff into their recovery sooner than I do now. You know, it's a challenge, but because postpartum, they just go out there. And I will add one more thing, even though it's not within your thing, is, as most of you probably know, most of these women's pregnancies are unplanned. There is a great paper that was just published by Sarah Heil, it's in JAMA, about using incentives for coming to contraception visits, not contraceptive use, but just to come to visits to talk about family planning. I think family planning needs to be discussed. It needs to be discussed with every patient. And I tell people, if you want to have closely spaced pregnancies, that's fine, but I want to make sure that you're on prenatal vitamins, that you're stable in treatment, that you know that's something that you're making a choice to do. So family planning is critically important. We see them, some of them show up for their 6-week visits, some of them don't. The MAT providers are ironically going to be the ones that are probably going to see them the most. And so figuring out that treatment approach so that we get family planning in there is also going to be a super important thing. And the author's name is Sarah Heil. Here, I think I can type and send this to everybody. And it was in JAMA just this past week.
Excellent. Wonderful. I was going to ask you how to spell her last name. What we can do is we can link that article and put that in the library under our publications. Well, while you were talking, you kind of opened the door on some other questions that came in. So one is, what do you see is the role of physicians in addressing social determinants of health?
You know, there is nobody that's going to manage this alone. And I don't have to tell anybody here that we're way too siloed, and that's part of the problem. Now, I don't know what state you're in, but we actually have an integrated program in Vermont that's called the Blueprint, that brings a lot of social services into the doc's offices. And I'm coming back to there's no question that we play a role, but the question is do I as a personal provider play a role, or do I need to make sure that I act as the place that patients can come, kind of like one-stop shopping, to kind of get a handle on on all their needs? And I will tell you, I take care of a lot of diabetics in pregnancy, and it is very much the same. Their care is multifaceted. As close as you can bring, and we've worked on this a lot, as close as you can bring your health department services and all of your services into where the patients are. And what happens is they tend to be in the doctor's office. And I always joke around, they tend to be in your big box store down the road. I'm going to get to that in a minute, because I kind of want to set up a clinic down the road in like Walmart, so that because people are there. I want to go to where the patients are that need the services. And when they're in your office and then they have to go to another place across town to get their WIC or to get their nutrition consults, it's a big barrier, right? It's hard enough to get them into the office. So 100%, we play a role with that. That's why I want our recovery program not to just be about MAT, and even not just to be about MAT and counseling. I actually want to bring in, if I could have one wish, job training. So there's another article you need to read about that. And you guys can tell me if Dr. Patrick talked about this, because he actually did the article that was also in JAMA in 2019 that looked at the socioeconomic structures of NAS. And there's a really good editorial that in some ways is more telling than the article by Katie, who's got a long last name. She's from, I think, Minnesota. I can find you that. I can send that article around. I was just reading it the other day. But it was also in JAMA in 2019. But it, and it really talked very specifically about this is what we need. We need to develop a better infrastructure for probably people in recovery, but I would say particularly women in recovery. Why particularly women? They are young, they are early in their disease, they are caring for children that they want to keep, and getting them on a solid, economically independent, solid footing will reap so many benefits down the road. So the bang for the buck is actually our patient population in terms of looking at job recovery and just basically job training and job acquisition. So if I had only one wish, it would be that. But that's pretty much what this is. And I'm going to actually, while you're queuing those things up, I actually just emailed this article to somebody. So I'm going to go look in my Outlook and I'll give you guys the reference. But did Dr. Patrick talk about it yesterday? I figured he would. That's why I didn't include it.
He did discuss poverty during his call. During his speech with us. I'm uncertain if it was a direct reference because I couldn't read it at the bottom. I think I may have grabbed it, Dr. Meyer, but
here I have it here.
Why don't you put it in there just to make sure we've got the correct one that you're referencing? So
yeah, no, and actually, and actually, I loved okay, I don't know how to attach a file.
Oh, you may not be able to attach it to the chat box. Oh. If you email it to us, then we can put it directly in the library. Yeah,
I can do that.
Yeah, okay. All right, excellent. Okay, we have another question that came in while you're, multitasking. I want you to start thinking about this one. Oftentimes we support and transport our women to their first postpartum checkup. Are there any suggestions that you can give to us as to how to best support that appointment to better address postpartum needs?
Yeah, first keep typing so that I know exactly what you're asking. Here is what makes me a little uncomfortable. I actually talked to most of my patients about this. There's nothing magical about postpartum care. I think the insurance companies probably just made it up so that they can end postpartum care at some period of time. And if they only do pregnancy coverage at 6 weeks, there's nothing that's normal at 6 weeks, right? Your body's not back to normal. You're barely learning how to breastfeed. You haven't dealt with hardly any of the pediatric stresses or anything having a baby. You're just coming off of when people are you're just coming off of when people are like rallying around your pregnancy and delivery, and you're just probably starting to feel a little bit more alone. Now, that said, your 6-week visit, family planning, family planning, family planning. That might be the best thing that you can make sure people, it is funny, women do not want to talk about it at 6 weeks. They say that they are not ready to decide anything. They don't like any of the contraceptive options. I am sensitive to that, and I kind of agree with them. But no one, I don't think that there's really any place else that's going to focus so carefully on family planning and what your needs are from a family planning standpoint. So that would be what's the most unique about that 6-week visit. And the second thing would be to make sure that as the patient has that care and then transitions out of the OB's world, that they have a primary care provider. Because I do realize that many of them might have an MAT provider that may not see themselves as a primary care provider. So a lot of them need treatment for hepatitis C, for example. They just have their general health needs. And to get them used to interacting as a patient, they rightly so, there's a lot of stigma. They don't totally trust the medical community. It might have taken you like the whole pregnancy to get them comfortable with you. So I would say family planning, because that will be addressed specifically at the 6-week visit. What do they think about how they're going to get their primary care moving forward? And ideally, even make an appointment. They may not have a provider. Facilitate making that appointment so that they have it. They have somebody that's identified and they have an appointment to go and see them. And I would add, look at whatever medical things they might need, right? They might have diabetes, they might have hepatitis C, they might have these other things that are put off in pregnancy that they need. So I don't know if that answers your question, but I would look to, again, I think the issue of primary care, in addition to employment, the primary care thing would be my other wish list.
Can you speak to mental health issues in addition to substance use disorders in pregnant women and its impact in the postpartum period?
Yeah, that's another place that honestly is why this primary care lens is so important. There's no question that there's postpartum depression, and as you know, most practices should be screening for postpartum depression at the time. The reality is we're actually doing screening a number of times during pregnancy. And as you also know all too well, because Dr. Patrick demonstrated this in one of his articles very well, is not having sufficient mental health supports is actually one of the greatest barriers to successful treatment, retention, and that continues postpartum. Women definitely have difficulty with postpartum depression in that first 6 weeks. Now, the good news is the OBGYN offices are on that. Usually, most OBGYNs feel comfortable initiating treatment, referring people to care if they can. But the problem is many of them are not primary care providers. They may not see that patient in the long run. And so again, they'll give a patient a prescription, but how effective that is and who follows that in the long run may still be uncertain. And so the good news is that in that postpartum period, those of you that are advocating for recently delivered women can usually call an OBGYN office and get medications for them, especially for depression, but may have trouble with continuity. And so again, it's going to be that PCP transition. Women who have more complicated mental health disorders and mental health needs, that is going to sadly have to come back. Postpartum will always exacerbate those things, not just because of the well-known postpartum depression, but just because of being a parent, right? It is a really stressful period of time. Again, these women have a lot of competing demands. I believe that we contribute to some of their anxiety, which is why I want to look more closely at how we're supporting women postpartum. And I would encourage you to look for those conflicts and help the patient navigate between between her competing places. But sadly, it's going to have to come back to where you get your mental health services. So I guess my only other comment to that is that if you know during pregnancy that there is an unmet mental health need, because of the way most practices work of giving some priority attention to women that are pregnant, if you can get them into treatment during their pregnancy, then they'll be looped into the system and they'll be able to continue then postpartum. So if they have an unmet mental health need, I'm not going to guarantee that the OBGYNs will pick up on that. I would hope to think we would, but I'm going to just be realistic about it. But to use everything you have and using the pregnancy as a priority to get them treatment in pregnancy, because then they'll be looped into the system postpartum. It's very difficult to initiate things postpartum because, again, they've already got all these competing demands and then they kind of fall off of people's priority list. I don't know if that answers your question, but.
I think it did. It's a good answer. Thank you very much. But another question that came in that says, oftentimes our clients use their families and informal support systems as their strongest reliance. Are there any suggestions that you can provide to us to better interact with families and support systems for our clients during the postpartum time?
That is a good question because families and supports go both ways. If they're truly supported, I guess to me, and again, I haven't seen any literature on this, but in general, if those individuals can come to the appointment, even if it's just one main support person, can come with the patient to all of those appointments and sort of be a voice to ask questions and be there, I feel like that is by far the most effective. And I'm going to give you an example. Again, I had a young patient who actually had very bad type 1 diabetes that she was really struggling to treat, couldn't get herself just where she needed to be at the time. But she often had a ride with her that was a very strong support person. And ultimately, with these conversations with the patient, the support person, and us, over a few visits, trying to convince her to come into the hospital so we could figure out what was going on with her insulin, we finally got her in. And we switched it around. And I just saw her last week and she's like doing so much better. And I could tell her she's a young kid. So I could tell her, you're doing so much better and you're going to feel better. It was just really satisfying. So having those people in the visits, super helpful. Because me as a provider, there's still a little of this going on. I think in terms of if they really want to trust you, it's not worth it. It's a lot of work, blah, blah, blah. But having the family support to be there to say, look, we're going to be here for you too, super helpful. So bring them all in. I know that in COVID world, there were some restrictions, but we do a lot of family stuff with, even with telemed. So I would say really try and get the support people at the appointments there because the doc will say something, but it won't necessarily translate. It's super helpful for those people to hear it. So I don't know if that helps either. You can let me know.
That was good. I actually have a question myself, and you spoke during this morning's presentation about smoking and the severity of NAS. And I'm just wondering if you can take that into the postpartum period and help us in looking at smoking if it increases after the baby is born, or how to really begin to kind of maintain, you know, if there was a reduction, you know, what are some suggestions that you might be able to give us regarding smoking, even during the postpartum period as well?
Oh yeah, that is, you guys are not easy, man. That is another tough one. I have to ask Sarah, if anybody did anything on postpartum stuff, it would be Sarah Heil, but you have to realize these patients go way like out into the ether. So it's super hard to get long-term data without a structured trial. And the short answer is, I don't know, except for the fact that I can tell you, during pregnancy, I put smoking on their problem list and I talk about it every single time I see them. That is the only way to do it. It would probably be best dealt with in that MAT space. The pediatricians are very, very good at that as well. You might want to circle back to the peds people in your community. And I know that our pediatricians are increasingly asking about maternal behaviors like that. As you know, there's a whole literature on smoking cessation. I'm not the person to give that particular talk. I do find that just as I talk to women all the time in pregnancy, that if I come at them as I need you to try and quit smoking, it stops. It's hard for them. So I rarely will come at it from a cessation standpoint, but rather a safety harm reduction standpoint. Try and smoke as little as you can. I talk to them a lot about smoking in front of the baby and other people smoking in front of the baby. Many of them, you know, and smoking in the home. So having those conversations about how it might impact the baby's lungs, the baby's development, the baby's growth, I think are going to be more impactful than a lot of other things. But I also think, and you know, whether or not how good some pharmacology things are versus a weaning program versus behavioral versus incentives. Again, Sarah Heil is your woman there. But postpartum, I would say, you know, going after it from the general smoking in the house part. And I actually, if moms have been able to successfully stop smoking, if the partners are there, I always turn directly to them and I'm like, so do you smoke? And I'll have a conversation about that, because if the partners are still smoking, it's very difficult for the women to remain abstinent. And of course, that's the same for opioid use disorder. But yeah, I wish I had some magic on postpartum, but this just has to do with what does primary care look like in rural areas? I just, you know, that first slide, I could do another whole talk on women in primary care in rural areas and chronic disease. It's a big, it's really, really tough where you guys are. So harm reduction, encourage reduction. Don't go immediately after cessation on the upfront. Because, well, unless you really feel like that's what they need to hear, because otherwise they kind of shut down.
Excellent. Thank you very much. Those are all the questions that I have that have come into the chat boxes. Just want to open it up for participants if there's any final questions that you would like to ask Dr. Meyer. Type away. Okay, I'm not seeing anything. I would like to just thank you on behalf of both HRSA and JBS for not only the plenary speech that you gave presentation this morning, but then also your availability during this Affinity session. Thank you for the support that the University of Vermont, Cora, has offered to all of our RCORP grantees. You guys have been just incredible in the resources that you provide to us.